now be recorded.
We're being recorded apparently. So welcome everybody. I would like to do acknowledgement of country. I'd like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. We recognise their continuing connection to land, water and community and pay respects to elders past, present and emerging. We also extend that respect to any Aboriginal colleagues who may be joining us tonight. I'm Margot Woods, I'm a GP in Rozelle and also on the board of Central Sydney GP Network, and I'd like to welcome our presenters tonight, Miranda Shaw, who's General Manager of the RPA Virtual Hospital, and Dr Owen Hutchings, who's the Clinical Director of RPA Virtual. This is going to be a slightly different event to ones that you may be used to attending before. It's going to be more interactive. There are only about 30 of us, I think, hopefully here tonight. So we're going to listen to some presentations initially, and then we're going to, you can add your questions to the chat box there. So we'll be taking questions that we'll answer at the end. But also we're hoping at the end of the presentation to actually open up the microphone to live questions. So while we're having the presentation, I really appreciate everyone to mute themselves while we listen, and then we will be getting into our questions towards the end. And if you're having any troubles with your audio or visual, just I guess check your internet connection and try and reloading the web page. Unfortunately, we can take messages, but we can't really troubleshoot for any technological issues. So let's get into it, because I'm really excited to hear about RPA Virtual Hospital, who you must say has had a very interesting, very rapid development from a great idea, but certainly did you hit the ground running, Miranda, or what? It was quite a precipitous introduction to the world, wasn't it? So over to Miranda, who's going to talk to us about RPA Virtual Hospital.
Thanks very much, Margot. And yes, we did hit the ground running. Owen and I are very pleased to be here with you tonight to provide you with some more detail about our journey so far, but also where we're at 7 months into implementation of our virtual hospital model. So this infographic really just illustrates that we launched on the 3rd of February this year, which is, just under 8 months of operations so far. And to date, we've seen just under now 4,000 unique patients registered with us for virtual care. It's been a very busy time. In preparation for the launch of RPA, we spent more than 100 hours over the summer months consulting mainly with clinical leads in our district, but also with the PHN, whom we met with a couple of times, in preparation for our launch and the initial models of care that we would include at launch. This slide is to provide you with some background of what our organisational structure looks like. We have a fairly standard hospital-like executive and support team there at the top, but you can see highlighted in the red box our new virtual care centre. When we launched, we had a small number, a handful of registered nurses in the care centre, and due to responding to the COVID-19 pandemic, we were required to ramp up extremely quickly. And we now have over 51 multidisciplinary FTE within that virtual care centre. Underneath that box, you'll see Sydney District Nursing, and I'm sure many of you are familiar with this service. Sydney District Nursing has been delivering care in the community for over 100 years and accepts direct GP referrals. Sydney District Nursing is part of our RPA Virtual Hospital and complements the work of our virtual care centre. Just to note on this slide again, Sydney District Nursing has been delivering care in the community for over 120 years, and the acuity of that care has certainly increased over the time I've been managing the service, and I've been in that role for about 7 years now. At any one time, Sydney District Nursing is caring for more than 1,000 patients. Certainly this year it's been over 1,100 patients at any one time receiving care in the community. So RPA Virtual Hospital was established by Sydney Local Health District to develop very quickly and pilot a virtual hospital model. And it was the idea of our Chief Executive, Dr Teresa Anderson, who some of you may know, who's also on the PHN board. And really an initial motivating factor was projections for the volume of activity at RPA ED over the coming years. in preparation for a redevelopment of RPA Hospital. And those projections suggested that the emergency department needed to increase in size to become the same size as Canterbury Hospital. Thinking about the sustainability and feasibility of this, Dr. Anderson was keen to explore alternative and more sustainable models, hence the suggestion to pilot a virtual hospital model. As I've mentioned, we're a proof of concept trial, and that trial is occurring over a 12-month period, so through to the end of January in 2021. We've engaged the University of Sydney Menzies Centre for Health Policy to evaluate the trial for us. We have a number of objectives listed here, and they relate to the care we're delivering via Sydney District Nursing in patient homes and in clinics in the community, as well as the new work that we're doing through the Virtual Care Centre. Overall, our mission is to trial new virtual hospital models to reduce unnecessary hospital presentations, including ED presentations, to support shorter length of stay by allowing patients to leave hospital earlier, knowing that they are able to be remotely monitored from home. Obviously, we support general practice by accepting direct referrals to Sydney District Nursing, not yet to the Virtual Care Centre, but certainly to Sydney District Nursing, and mostly that is for complex wound care and community palliative care. Some of the features of the virtual hospital include a very comprehensive governance structure. In addition to the organisational structure I showed earlier, we have a number of high-level committees in place that include representation from the Ministry of Health and also the Australian Commission in Quality and Safety in Healthcare. And they're really to ensure that we perform as well as we can during this trial period at the quality and safety of our virtual clinical care, and to support us in research and innovation. We've realised, and we did realise extremely early on, that strong local relationships with our bricks and mortar hospital specialists are really critical to allow us to develop safe virtual clinical models of care. And that includes escalation and assessment pathways that are agreed in advance with those specialist departments. We've really lent on these relationships in our pandemic response, and Owen will discuss those later on. We're a district-wide service. Although we're called RPA Virtual Hospital, we actually provide services across Sydney Local Health District. And our virtual care centre is 24/7. It's staffed by RNs 24/7 and has an on-call medical roster for that time as well. Mostly this is for deteriorating patients who need to contact us through the night. We have a 1-800 number with various phone queues depending on the patient type who's calling in. As I mentioned, the new Virtual Care Centre complements the work that's being delivered by Sydney District Nursing on the ground, in patient homes, in virtual beds, if you like, virtual hospital beds in the community. We have care pods in the Virtual Care Centre, and these are really workstations where our clinicians are based. And each one of these includes multiple screens, a good webcam, a headset, an iPad, and capacity to video conference. We have been providing patient wearables for our high-risk COVID-19 positive patients. And important for your information in particular is that we made a decision to classify our patients as outpatients rather than hospital inpatients, and that allows us to collaborate with general practice. In saying that, we are working very closely with the Ministry of Health and also the Independent Hospital Pricing Authority to determine what is an appropriate funding model for a virtual hospital. We've worked with the Health Pathways team to develop a GP e-referral form that we hope to use in the future when we're able to accept direct GP referrals into the Virtual Care Centre. And we're exploring a care planning platform known as the Diary that allows for patient and clinician and GP views simultaneously. These are some images of the care centre and the care pods that the staff use. And on the right there is a patient kit of wearables. Our implementation plan for the 12-month trial period is really across the top column there, the top row in the table there. This is what we had hoped to implement before we realised that we were to have a role in the pandemic response. When we launched with 3 patient cohorts. We launched with stable palliative patients who are receiving community nursing care. We wanted patients to be able to report their symptoms daily, to keep a closer eye on them, and to be able to escalate and bring forward to bring forward in-person appointments as required, depending on deterioration of symptoms. So palliative patients are able to do that using a very simple survey on an iPad, and the results feed into our virtual care centre and are monitored on a daily basis. We partnered with the Cystic Fibrosis Service at RPA Hospital to support them in a randomised control trial for remote lung function monitoring of their cystic fibrosis patients using a spirometer that plugs into a mobile phone. And we initiated a very simple program of health maintenance messages that are pushed out mostly via SMS, but also with some phone calls to patients who've been discharged from Sydney District Nursing with healed lower leg ulcers. We did an audit probably 2 or 3 years ago now that indicated 63% of those patients were likely to represent to our service. We're testing a health maintenance program with those patients to avoid that representation. We're also about to start medication monitoring with our TB patients to avoid them having to present to the outpatient clinic at RPA. And we're doing some medication monitoring of immunosuppressed patients who need to inject, self-inject their medications. We've been planning in earnest for the introduction of an eICU service, and this is in partnership with Western New South Wales and Far Western New South Wales local health districts. And this is really for our intensivists to be able to boost their capacity to care for ICU patients, particularly after hours. We've recently, in the last 2 months, collaborated with the community mental health services to support them through our virtual care centre to monitor, prompt and monitor medication for community mental health patients, and to survey the wellbeing of their patients and provide some psychosocial support. We're hoping to work with renal patients on home dialysis, but that's yet to start. We're currently planning to support the Cystic Fibrosis Service with diabetes management and education for their patients. Sorry, I'm just having trouble seeing the entirety of my screen. Patients within the far right column, patients with low back pain, patients with chronic headache, and patients with minor fractures are all patient types that are on the top 20 ED presentation list for RPA Emergency Department in the last 2 years. And given our KPI of trying to reduce unnecessary ED presentations, we're hoping to introduce some virtual initiatives for these 3 patient cohort types. Patients with minor fractures, we're very close to launching a virtual minor fracture clinic, and we're hoping that will happen in the first week of October. And something else we do is after hours and on the weekends, we staff in a residential aged care facility triage line, and we monitor the ambulance board to avoid unnecessary presentations to hospital by residential aged care facility residents. Underneath is the pandemic response, and Owen's going to go into that in a lot more detail in a moment. So Sydney Local Health District has really been at the centre of the New South Wales response to the COVID pandemic. And in particular, we've done this by setting up what we refer to as special health accommodation or health hotels. And these are hotels that we run. They're under our governance. And they're under, in particular, the clinical governance of RPA Virtual Hospital. We have RNs and allied health staff on site in the hotels, and medical care is provided virtually, along with other specialised care delivered virtually. So RPA Virtual Hospital really in-reaches into these health hotels to provide care for patients that are in quarantine. Now, the patients that come into these health hotels, as opposed to the other police-run hotels, are either patients who are COVID-19 positive, or patients who have symptoms of COVID and are pending a test result, or they're patients that have complex clinical care needs that are unable to be met by Healthcare Australia, who are delivering clinical care in the police-run hotels. This timeline here just shows you the movement we've had and how we've had to respond to the changing patterns of returning travellers to Sydney since the pandemic began. To note, I've put at the bottom there the proportions of patients who are in health hotel quarantine who have returned from overseas. And right now, that is mostly expatriates who've been living overseas for some time. So you can see we've got, as at today, we've got 433 patients being accommodated in our health hotels. 329 of them are overseas returned travellers, mostly expatriates. 29 are travellers who've come to Sydney from interstate, and only 75 are from the local community. And that's not necessarily the boundaries of Sydney Local Health District. That's non-travellers who may need to quarantine for particular reasons. This is just a breakdown of what the activity of our virtual care centre looks like, and this is data as at today. So you can see overwhelmingly our activity has been concentrated in the pandemic response. As I mentioned, we hadn't foreseen a role for RPA Virtual in the pandemic response, but we did move into that space very quickly, and we started delivering care from early March. The other patient types are split there as well. You can see, though, that they represent much lower activity. And finally, I'd just like to reflect on what our patients have told us about their experience of receiving virtual care. We put particular effort into making sure we're asking patients about this. You know, it's a really critical part of the evaluation of our trial, but we also need this to continue to refine our models of care as we progress through the pandemic response, but also as we progress through our trial period and introduce new initiatives and work with different patients. We've been really surprised at how positive patients have found the experience of receiving virtual care. Overwhelmingly, patients have rated their care very highly, and they have engaged very well with the technology that we've used. So you can see just under 90% of patients have rated the care they received from the virtual care centre as good or very good. 90% felt the care and treatment had helped them. The technologies used improved their access to care and treatment. The nurses met their needs. The information was useful. Probably most important to point out in terms of the pandemic is that patients felt very confident at home knowing that their symptoms were being monitored. They found the video conferencing system easy to use, and those small proportion that received the wearable health devices for COVID monitoring found them easy to use as well. So thank you. That's the last slide in my presentation, and I'll now hand over to Dr. Owen Hutchings.
Thanks, Miranda. That was really, really interesting. And we're just going to do a bit of technology swapping over to Owen. But what an interesting broad number of patients that you're seeing. But I guess the pandemic is what we're all waiting to hear from Owen. So welcome, Owen.
Hello everyone, good evening. Is the screen visible there to you?
Yes, it is, Owen.
Yeah, great, okay. Thanks Margot and thanks Miranda. So Miranda's painted a really good summary there of the virtual hospital and the background to the project for us. And what I'd like to talk to you tonight about is really the virtual hospital's role in the pandemic response. 2020, as Miranda's highlighted, has been a very interesting year for us, and we've been pivotal in Sydney Local Health District's response to the current COVID-19 situation. And I'd like to just present in much more detail what that care has looked like for us, what the virtual packages that we've had to put together have included and incorporated through the challenges of responding to what's been a very difficult public health situation. Some of you may be aware that I presented earlier in the year. Apologies, I'm just trying to get to move on to the next slide. There we go. So some of you may be aware, may have attended a session earlier in the year where I presented on RPA Virtual's COVID-19 remote monitoring program. But just to summarize and highlight some of the key points from that, you may be aware that earlier on in the year we were tasked with the responsibility of looking after COVID-19 program care into the community. And at breakneck speed, we were tasked with designing a clinical protocol and remote monitoring program that enabled the system to care for people in their homes. That was quite a challenging time because obviously it was a novel disease in a novel country with a novel facility, and we were building a novel program to look after that condition. And although there was some evidence coming in from overseas and internationally around what the disease looked like, we were really in the situation of having to learn on our feet and respond as we go. So we built a remote monitoring program that involved remote oxygen saturation monitoring, temperature and pulse rate monitoring, and really targeted the assessment and detection of clinical deterioration. In order to do that, we built a clinical protocol, which I'll show you in a second, and that was a nursing delivered protocol remotely administered to people in their homes, and ran through a whole series of nursing-based assessments, clinical assessments, and remote monitoring observations to identify people who were at higher risk and becoming unwell, and then obviously escalating on to high-level services as required. As we matured and evolved and learned through that journey, we then built a risk stratification tool, and with the evidence that was available overseas and locally, as the year went on, we then developed eligibility criteria for our community program, as well as risk stratification. And really the aim to do that with recognition both in Australia and overseas that obviously the milder elements of the disease required less prevention and monitoring. It enabled us to focus our services and focus our attention on the higher risk, more unwell people, and that relationship into the hospital. So this just gives you an idea. We stratified people based on age, their medical history, and their symptom severity at the time. There were some caveats to that in terms of specific risk factors. So we identified particularly hypertension, children, and pregnant people as requiring more further consideration. I just want to spend a bit of time talking to the risk stratification. So with the evidence available, we broke our patient cohort down into the groups, and Miranda's highlighted some of the size of that activity data that we had at the time. But what we were then able to do is tailor our care package. So we started with a sort of one-size-fits-all approach, and then as we had access to further evidence, we became sort of more refined in our approach and built a program for the low-risk patients and a program for the high-risk patients. We really focused our wearable devices, our resources, and our attention on the high-risk group. I've had conversations previously about the importance of our relationship with general practice and how we communicate and interact with general practice. And during this time, we built the necessary systems to make sure that we were keeping a patient's GP fully informed of what was going on, notifying GPs of people's admission to our program, and then the appropriate discharge communication back to general practice when the episode of care had been completed. At this point in time, we started to get to, I think, quite an interesting place where we wanted to interact with general practice particularly over the lower risk and medium risk groups, and work on processes and procedures to have general practice look after, their own patients if a patient had a GP that they knew well, facilitate care in general practice and support general practice to do that. And I think there was also a really exciting opportunity for patients to be referred directly into the virtual hospital for general practice for some of those medium, higher risk patients that required a higher level of intervention, rather than automatically going to the ED unless that was fundamentally required. At that point in our journey, the public health response, which is, I believe, has been managed exceptionally well in New South Wales, came into full effect, and really our community transmission activity for COVID-19 almost disappeared. So we never sort of got to that point in terms of the processes and mechanisms of really maximising and optimising that relationship with general practice. But certainly keen to revive that if and when should the need arise. I might just pause there also I'm not sure if Kate George is online, but we've had several discussions through this whole journey with Health Pathways and the Health Pathways team. And if Kate is there, I believe she'll want to mention some of the COVID pathways for health pathways that have been developed, both in the acute care and the post-acute care area. And that sort of ongoing COVID rehabilitation is a really interesting space for us at the moment, and there's lots of very active discussions, both with the hospital system and general practice about what that might look like, and that's reflected in the health pathway conversation. As I mentioned, we have a pretty robust clinical protocol that we use and that our nursing team deliver, and that's really the tool that we're using to assess COVID-19 at the moment. We do have, as you'd be aware, we do have a little bit of activity in the community at the moment, but it's pretty minimal, and we're down to really less than a handful of cases per day that we stratify into that program. And I just highlight the point that this is within Sydney Local Health District. Miranda's already showed this slide, but I'll just talk a little bit more about the devices there in the center. So that's the package, that's the COVID-19 remote monitoring package that patients get given. And that contains the oximeter, contains the TempTac device, which is how we remotely monitor the temperature, and the oximeter obviously gives us the pulse rate. And the cost effectivity of that package is being evaluated through a costing study, but that is somewhere in the realms of, I think it's about $300, which is a fundamental part of being able to prevent the hospital admission. So a pretty crucial piece of kit sitting there. That's just a very brief run through of what we've done with COVID and what we continue to do. Without doubt, over the last 3 or 4 months, the COVID activity has very much existed in the hotel quarantine system. And I know that the hotel quarantine system existed in the media quite a lot, and people will have heard lots of different things around it, but people have varying degrees of familiarity with that program and what the processes are involved in that. So I'd just like to spend sort of 10 to 15 minutes going through what that looks like for us and what that journey's been. You'll all know that we're operating under the Public Health Gazette for air transportation, and that came in earlier in the year. And that was initially for cruise ships, but that closed down pretty quickly, and has now moved on to all all travellers and repatriating Australians are mandatorily required to take 2 weeks of hotel quarantine, and that can't occur at home other than by way of exemption from the Ministry of Health. And in my experience, exemptions are pretty rare and don't come around very often, and you have to have pretty significant health reasons to be able to quarantine at home. It also depends on where you've travelled from and what the risk of that area is, and what your structure is of being able to quarantine at home if deemed appropriate. So, for example, people returning from America on multiple flights to home isolation situations that are not ideal from a public health perspective are very unlikely to have an exemption granted. And the approach has really been to ensure that we support people within the health hotel system for issues of public health safety. What does the system look like? So briefly, all return travellers step off the plane to the airport, internationally and interstate. They are then assessed at the airport by 2 teams. One team is looking at COVID risk, the epidemiological risks, as well as the symptom risks and requirement for testing. And there's also a general medical health screen of general medical problems, general medical issues, what kind of conditions people are returning with. And this is really the quarantine system, and bearing in mind that that whole system is within a bubble of isolation and maintaining quarantine infection control. So it's quite a complex system. People are screened at the airport. Everyone is going to a police hotel under the Gazette by default, unless they are triaged off that system to two places. That might be the special health accommodation system, which I'll talk to in much more detail, and then an emergency department if that's required. So if someone has significant health needs that would require admission to hospital, or an acute condition requiring ED assessment and investigation, they'll go straight to the ED. If it's a chronic health issue that requires additional supports to that could be provided in the police hotel, then they will be referred to us in the special health accommodation. And that ellipse around the special health accommodations really highlighting the role of RPA Virtual and what we do. The quarantine period is 14 days, unless you've got COVID, in which it could change. And then there's onward travel and onward discharge. Now, that may be to their homes in New South Wales, or actually much more frequently it's interstate and sometimes even internationally. And as Miranda's highlighted, it's a very small proportion of the people in the quarantine system that are actually from Sydney Local Health District. I just want to make the important distinction that the police hotels are not part of the health agency, and they do not belong within the governance of Sydney Local Health District. They're an entirely separate entity. When this system stood up, and everyone stood up the systems very rapidly, there was a lot of movement in this system, and we've worked really hard to identify early where people are best placed and where they best belong, so that we can minimize transmission and movement within a potentially infected system. Just to talk briefly about RPA Virtual, SHA, and the relationship with general practice. So as I've mentioned, we provide extended clinical services to the special health hotel accommodation. The special health accommodation team and RPA Virtual are actually separate facilities, but we work together very hand in hand as a single entity. I've deliberately put a picture of a handshake there because that's something we're probably all missing from this year, because we haven't been able to do that. But we virtually handshake with the special health hotel accommodation system to be able to provide care. We do very strongly encourage people to contact their own GP in the first instance if possible. And if a person's GP is available and can reach in and provide services via telehealth and maintain good primary care of that patient through their quarantine, we certainly strongly encourage that. Although we do find in our experience that probably around 75–80% don't have such a GP, or that GP is not available, or they don't have telehealth capability. So it's quite a high volume there. We make the decision to admit people to SHA on clinical grounds, and the medical staff then continue to provide care. We use the between the flag system to detect any deterioration, and just highlighting that we do have patients in the system who both have COVID and both who don't. So care is then escalated to RPA Virtual by the special health team, which I'll talk a bit more about in the moment, and we involve the GP when able and appropriate through that journey. We respond in a duty of care way, so we're not case managing 500 people in the SHA, because our team would be too small to do that, and they are outpatients in the community. But regular welfare checks are provided. This quarantine is a really trying time for people, and it really tests people's mental mettle as well as their physical health. So regular welfare checks are conducted to make sure any issues are highlighted early and escalated appropriately. Through that 14-day period, once care has been, or the quarantine period has been concluded, we then go through quite a complex discharge planning process. So for positive patients, that's a criteria-led discharge plan to make sure that we're meeting the CDNA requirements for discharge from COVID care, so we're not releasing people too early. And that's been a significant part of public health response. It's really quite a complex process of public health and health approval to release people at the right time and to make sure that people aren't de-isolating and contaminated too early. Our negative patients that remain negative through their quarantine are supported by an entirely separate team that do an awful lot of work around exit swabbing, chasing the results, talking to public health, complaints, patient information and education, and then the administration for the discharge process. For some of the more complex discharges back to community, particularly for people that don't have GPs or are travelling interstate to other services, we've had to do a lot of multidisciplinary discharge planning activity involving social workers, psychologists, child and family clinicians, etc. I'm just conscious of the time, so I'll race on through a little bit, but just to let you know what health hotels look like. So they have a extended team of executive from general managers down through all sorts of corporate services, data managers, bed managers, infection control, and administration support, as well as support from the clinical governance unit, and support to the exemptions process, and also importantly the complaints management process. There's extensive nursing and allied health staff on site that provide multiple different functions, and obviously it's a 24/7 service. It's a quarantine hotel, so RPA Virtual provides support from a 24/7 perspective. Miranda's already touched on the hotels we're using, so we can move on from that. I just want to pause here and highlight the complexity of what we've done. I've been absolutely blown away professionally by the level of complex chronic healthcare needs of people who are traveling, and it's quite remarkable that these people have physically and mentally been able to get on a plane and travel back to Australia during this time. Because of the complexity of people in the health hotels, we've got families, you know, COVID and quarantine affects families, it doesn't affect people in isolation. We have significant extended large families coming back into quarantine, often from quite difficult personal circumstances. They've been overseas to deal with a bereavement, they've lost jobs overseas, they're returning from extended periods overseas and don't necessarily have jobs and families and homes and social setups to come back to. So you know, people going through a really trying experience, and it's often taken them quite a long time to actually get back to Australia because of the cap at the moment. So within the virtual model, we've had to build mini models of care specific to clinical streams that meet particular clinical needs. And we've built these virtual cohorts into the special health system. And the ones I particularly like to highlight, because they've probably been the most complex, is mental health. So significant activity like for our psychological services, and escalation to Marie Bashir as the inpatient assessment, to the emergency department, and through the mental health intake line for acute mental health services. So we're very closely supported by mental health because that's been a significant burden of disease in the quarantine quite naturally. Aged care, we've had people returning with all sorts of cognition, mobility issues, sometimes even some delirium issues, and particularly around complex care needs, polypharmacy, and care in the community, and carer needs as well. So we've actually worked with our aged care model to build a video consult virtual in-reach model, whereby our aged care specialists actually reach in and assess people, often using an interpreter in the health hotel, in order to keep them there when possible. You'll understand that we want to minimize attendance to the hospital as much as possible because these people are potentially COVID carrying. So we don't want to expose the hospital system to that potential infectious risk unless it's absolutely necessary. The antenatal clinic, we've built an RPA virtual antenatal clinic. A significant number of women have been returning from overseas, pregnant, often quite late gestation, without Australian standard antenatal care, sometimes no antenatal care at all, and some almost at the time of delivery. So we've built an antenatal clinic backed up by a specialist fellow, and they will reach in to provide antenatal services. And the complexity of that, again, has been quite outstanding. And we usually have somewhere around 20 to 30 pregnant women on the books there. And that service also reaches into the police hotels. There's currently about 5,500 to 6,000 people in the police hotel system, and we generally have about 10% of that in the special health hotel system. And obviously, we're expecting an increase in the cap, which we've seen in the media. So really about to increase. We have to talk about alcohol, substance misuse, opiate misuse, and benzodiazepine use, and there have been some significant issues in the health hotel system with that. So we've worked very closely with our addiction medicine specialists around how we manage those processes, and particularly just keeping people safe through the quarantine process, and making sure that people aren't overdosing or withdrawing without support. I'll just mention paediatrics as well. We've built in paediatric support, particularly around paediatric COVID assessment. So that's something we've worked very closely with. And all of this obviously is under the relationship with public health and the public health response, which essentially is why the Special Health Hotel exists. And it's quite peculiar to our district and to our area. Just to quickly talk about some of the data. So our data analysis, people told me today that this is actually probably an underestimation of the data. And our total occasions of service of care into the Special Health Hotel system have been somewhere around 40,000 to date. And that's roughly for about 4,000 patients. So each individual person or patient for RPA Virtual is getting about 10 episodes of care. And you can see the trajectory there on the top left. The activity on the top right, that yellow bar, represents the COVID positive care that we've needed to deliver in the occasions of service. And then underneath that, we have the discharge team. So the green there is the public health discharge process activity for patients in Special Health Hotel systems that didn't have COVID. And then underneath that, we have the occasions of service for the medical, nursing, allied health teams that have provided care into SHAR. So you'll see it's a very high turnover and very high level of acuity for the service. And that's why it's been so resource intensive for us as a virtual hospital. That graph on the bottom left is basically showing the types of virtual intervention that we offer and how we do it, and the length of times for those services. So you'll see that roughly for every episode of care, the time of interaction is roughly about 20 to 25 minutes. So it's a significant volume of time. And then a distribution by age of demographics. So in that sort of late teenage to 40s, 50s age range. And we've had people right through to the very aged with some quite significant needs. That's what our care centre looks like. And just in closing, Kate may want to talk to the health pathways if she's online. But I'd just like to highlight sort of some of the complexity in some of the cases that we've had. And it's really ranged from really quite unusual circumstances and cases that have required quite a lot of multidisciplinary team management, engagement of all sorts of hospital and community services. As Miranda's highlighted, SDN sits as part of our workforce. And we have close historical links to community services and have really had to use child and health and family services quite significantly. The health hotel system in some ways is quite a pressure cooker. When we add all of those care needs, all those complex care needs into a quarantine system for people that are returning to an environment they certainly haven't chosen, it's been largely forced upon them. And we throw children into the mix. It's raised many complex care needs. We've been dealing with domestic violence and threats of domestic violence. We've been dealing with episodes of potential non-accidental injury and have had to engage all the specialist social work services to assist in those circumstances. We've had really quite unusual stories. We've had a 71-year-old man return from overseas with 8-month-old IVF twins that were his. Returning to Victoria with no real supports to speak of, so no partner in the mix, no supportive family, and no community services in place, and no pre-existing relationship with the GP. Some of these individuals have lived overseas for many years and often have had really quite significant complex care needs overseas that they haven't been tending to. So that talks to the complexity of the discharge planning and really making sure that we're engaging well with general practice, because our primary role has been to keep people safe and secure through their quarantine period. I'm not so sure that we can really make their quarantine period enjoyable, but make it more manageable, and then the responsibilities of discharge planning onwards afterwards. And it's really actually provided an opportunity in some circumstances for us to improve care planning, case management, and ongoing chronic care that we wouldn't have otherwise had. We wouldn't have otherwise had that opportunity. So we're very closely watching this space to see what the increased activity will do as we move on into the next phase of the response. Most of our models are largely matured now, and we've sort of we're still tweaking some of them, but they're pretty much refined. It's really now just a case of improving and continuing to deliver what I hope has been a high standard of care during a very difficult time. And I will stop there.
That's fantastic, Owen. It's what a huge caseload and what a complex caseload you've had. So that was a great summary of what you've been doing. So just we're now going to open that up to questions, and so you can either put your question in the chat box, so you can see that'll bubble up there. But you write your question in there, or if you'd actually like to ask your question yourself, can you just pop in there? I'd like to ask a question, and then we will go around and answer some of those questions. So while you're popping your questions in there or your desire to chat, we might just get Kate George, who I'm sure most of you know, who's both our clinical lead in Sydney Health Pathways and also, I think, GP advisor for the virtual RPA as well. I think those are both Kate's roles. But would you like to introduce yourself and just give us a little bit of a feel for what you've been doing in Health Pathways, Kate? Thank you.
Thanks, Margot, and thanks, Miranda and Owen, for that really detailed overview. I'm in awe of how much you've managed to get going in such a short amount of time. I'll just speak very briefly so that you can get to all your questions. The main thing I wanted to point out with Health Pathways, you may hopefully all have looked at our suite of COVID pathways. The main one that we've been working with RPA Virtual on has been the COVID-19 ongoing assessment and management pathway, which you can find under the, so there's a drop-down box that says assessment and management pathways. There's an initial assessment and then the ongoing assessment and management, as well as children and RACF. But the ongoing assessment and management one has been the one that we've worked with RPA Virtual on. And Owen alluded to it earlier, but the plan is that we're currently reviewing it just to update it because things have changed already. And we're in the lucky position of having one of our GP clinical editors actually working within RPA Virtual as a GP there. So he's got his finger on the pulse with what's going on. So that pathway is being updated. And if things change again, which things hopefully they won't, and the numbers get out of control, the plan is to shift the mild cases to general practice management, and we would alter the pathway to indicate that clearly. The other thing I wanted to let you know, which is quite exciting, is that Health Pathways Sydney is collaborating with Illawarra Shoalhaven and also Western Victoria to develop a post-COVID-19 conditions pathway, which basically is looking at all those things that appear to be coming out as, you know, post-acute phase, post-isolation period considerations, which of course we in general practice will be the ones managing. So that's well and truly in the pipeline, and you should be seeing that pop up on the site within the next month. So that's all from me, I think, Margot.
Oh, thank you very much. And I can actually pop those pathways up. So I might just pop them up off my screen whilst we're taking some of the questions as well. So that's just showing you the suite of the health pathways on COVID, and some of the ones that Kate was mentioning is really in this assessment and management section. So you can see we've got is that right, Kate? The assessment and management pathways. So these are the ones that Kate was mentioning. Is that right?
Yes, so it's the specific one relevant to RPA Virtual is the second one, the ongoing assessment and management once the diagnosis has been made.
So I'll just leave that one up, and just see. We've had a question from Natalie who wanted to ask about the special health sites. Are the ones that you're mentioning the only ones that are in Sydney? Are you looking after all of them, Miranda and Owen?
Yes is the answer. So it's the only health hotel system we're aware of. Different districts initially, when we started doing this, were handling this issue in slightly different ways. I believe Miranda might know more, but other districts have evolved their responses. But we do often get referred patients from outside the district, and we are often asked to provide the service to people who don't reside within this district.
That's right. There are some LHDs, Margot, that have limited accommodation for local residents who are unable to safely self-isolate, but they certainly don't have hospital inReach, and they're on a much smaller scale.
Anybody else have a question you wanted to raise? I guess while you're typing, I might just say it's obviously communication with GPs is always top of the questions. And I just wanted to say, you said you were going to develop a diary as a way of communicating with GPs. Could you tell us a little bit more about what that might look like?
Sure. So it's not a diary to communicate with GPs as such. It's a platform that displays a care planning app. It's an app that displays a care plan that the patient can view, the patient support network can view, the treating clinician, whether it be RPA Virtual or others in the LHD, as well as general practice and any private allied health providers. And when we received a demo of this, we thought it was something we would love to include in our model of care. So we're continuing to work with the company that have developed that, and hopefully we'll realise that in the new year. In terms of other communication with GPs, when COVID positive patients are registered with RPA Virtual and first referred to us, we send correspondence to their GP if they have one, advising them of the diagnosis and describing the model of care the patient will receive. And then at the point of discharge, we communicate again with the GPs and send them a copy of the criteria-led discharge form for the patient. We also ask all COVID positive patients to see their GP within 7 days of discharge from our service. And certainly all the patients that are in health hotel quarantine, the formal communication we send to them, we encourage them to continue to be in contact with their GP, and if their GP is able to deliver telehealth services to them in quarantine, we encourage them to arrange that directly with their GP.
Thanks, Miranda. There's a number of questions probably following up on that. So Annabelle's asked a question around, I guess a lot of us were maybe surprised there were a lot of people who aren't in our area. But for those who are in our area, is it possible to give them a list of GPs in the area that they may like to choose from, and actually those who don't have a nominated GP may like to take this opportunity to find a GP in the area?
At the moment, we're referring them to Health Direct, so they're able to do a search of local GPs, and we do encourage them to find a GP. But yes, as we've mentioned, the majority of them are returning to Australia for the first time in many years, haven't lived here before, and are really just beginning to set up their lives back here. And that includes obviously finding out where they're going to live and who their local GP will be. Owen, do you want to add anything to that?
I was actually going to ask a question back to the group, and this is something I've sort of considered before, and I don't know whether it's through the PHN, but is there a mechanism by which we could identify GPs for people that don't have them? And for that group of 75, 80 people in our district, I don't know if the PHN has any programs of plugging people into GPs like that, or is it that we provide the information and then people work that for themselves?
Did someone from the PHN want to reply to that? Natalie, is that a role, or Michael, that you feel the PHN could play?
Yeah, look, the simplest solution is to for them to look at the National Health Service Directory, which is a national database of GPs which maps practice locations. I think that's probably the simplest thing to do. If you wanted to give them a list of GPs with a special interest or special expertise, that would be a different thing, and we have done that in the past. So, for example, you know, gay-friendly GPs, GPs that have got interest in children and so on. So if you did want to have a specialised list of GPs, we could certainly talk about that. But in terms of, you know, who's the closest GP to where you live, probably the National Health Service Directory is probably the best bet.
And the other point would be to make that getting a GP or finding a GP would be a great thing to start on day one. So they've got 2 weeks to actually ring around, make appointments, and actually do some telehealth connection with a GP to see if they are the right fit. And I do appreciate that not everyone knows where they're going to be living, or some of those people may not actually have all that worked out. But we're really keen as GPs to actually have these people link up with us as soon as possible. If they haven't got a GP, then hopefully one of us can actually take over for them, particularly as you're saying that so many of them are very complex patients, aren't they? So to be...
And on that point, we've been through this process of having to sort of MDT discharge planning processes for care. We've literally just this last week or two had conversations with the health hotels about really starting that MDT process as early in the quarantine as possible, exactly for that reason, so we can start identifying who the people we need to involve are, and obviously the GP is completely centric to that.
Yeah, I think we're all aligned on that one. So Jenny Morrison's asked a question, which is a really important one. You did mention, Miranda, about making sure that these people are classified as outpatients, but just to clarify what that actually means, and that means that if they're outpatients, GPs can still use Medicare to bill patients they're doing telehealth consults with. Presumably we can do mental health care plans and send them to psychologists for assessments, things like that. Whereas if they're inpatients, it's actually not okay to use Medicare. So that's the important point. Have I understood
That's
that?
right.
Yep.
Absolutely, and we made a conscious decision to do that so that we wouldn't preclude GPs from being involved in their care. And we really want to collaborate more closely with general practice as we evolve the model and possibly, post-pandemic. For example, the virtual fracture clinic that we're about to launch initially will be taking referrals from patients presenting to the emergency department who are able to receive virtual care rather than go to an outpatient clinic. But as we establish the service, we would like to be receiving referrals directly from general practice and bypass the ED presentation altogether.
That would be fantastic. And I think Penelope's asked about communication and making sure that it's electronic. And I heard you say that you're setting up some electronic referrals as we speak. Is that right? Yeah. So for referrals of both directions.
Yes, we use secure file transfer to send correspondence to GPs now, and I mentioned we've established an e-referral form so that when we are able to open up referrals from general practice, we'll be able to use that immediately.
So I'm assuming that will work in a similar way to the e-referrals for haematology, rheumatology, etc. at RPA. That's fantastic.
Exactly the same, yeah.
And we've got a question around the fractures that you've been managing. So when would it be appropriate to manage a fracture through RPA Virtual versus the fracture clinic versus the fracture clinic at Balmain? Will that be something that Health Pathways might be able to lay out for us in the future, or do you already know?
Great question for Owen.
Well, I wouldn't say we already know. So this service is about to launch. We're actually replicating precedent models from interstate. And interestingly, what the models have shown is that you can replicate about a third of a traditional orthopedic trauma fracture clinic in the virtual setting. So it's a significant improvement in terms of the patient journey and patient experience. And that, I guess the journey for me and for us really started in Balmain with minor fracture clinic. What we're doing is working, that service is very heavily allied health and physio led with our physios across the district to make sure that we're communicating mechanisms from the ED through the fracture clinic to the virtual fracture clinic and including Balmain. So there'd be processes of triage as to who goes where, and very strongly for primary care that would be from through Health Pathways. I think anyone that knows me and with the work that we did at Balmain and setting up the clinic, my passion was to provide a service that GPs could refer directly to, and that's certainly what we're very keen to do with the virtual fracture clinic.
That sounds fantastic. So being the parent of what seem to be accident-prone children and spending hours and hours at the fracture clinic at RPA, I thank you very much, because it's a very long wait. So just one question. Oh, sorry, yep.
So I was just going to say the idea behind that model is that you'd be referred into the fracture clinic, you'll be assessed virtually by a physio and virtually by an orthopedic surgeon, and then potentially receive your entire journey of care virtually, apart from obviously any immobilization or plastering or anything you need, and it would interdigitate with the traditional clinic.
Fantastic. Annabelle's asking, who looks after the health of the people in the police hotels?
Good question. Healthcare Australia. So the police hotel is quite a different structure. It's a police managed hotel under the governance of the police and the police agency and the police minister, and it's staffed by police and security. There are doctors and nurses from Healthcare Australia who are there to provide responsive services, but really if there's any ongoing clinical need, anything more than a sort of one-off fairly rudimentary intervention, they get referred across to us, to the district.
And presumably they can also access their GPs and telehealth as well, the people in the police hotels.
As far as I'm aware, most of the police hotels are actually in the CBD and out at Homebush, I believe. But yes is the answer.
And you mentioned the kit that you send to the patient, so about $300 worth of equipment. Is that kit retrieved, or do those people actually get to keep that? So someone who's been looked after by you may actually now be the proud owner of an oximeter. Is that correct?
I might let Miranda answer that one.
Yes, we do foot the bill for providing patients with that kit. We were looking very carefully at infection control because we were dispatching them to COVID patients. We decided that it was a small investment to make. The kits are delivered directly to the patients by a team that we call the Flying Squad, who are fully PPE'd up. And yes, the patients get to keep the pulse oximeter after their care is completed. And the kits are $309 each, so very affordable.
Well, compared to a visit and care through an emergency department, that's actually quite cheap. Compared to a visit to a GP, probably not. But anyway, I'll leave that one there. So look, I really appreciate you. I think we've covered all the questions. I really appreciate, I guess, the care, the amazing amount of work and systems that you have both developed. I hope that you're actually both going to get a bit of downtime at some stage. It sounds like it's been a total whirlwind. And from people on the front line of general practice, really appreciate that we've actually had the assistance, particularly with the pandemic, to look after a lot of patients and keep up the good work with that communication and coordination with general practice, because we definitely want to work together really well. So I really appreciate it. Thank you so much, Miranda. Thank you, Owen, and good night. We're right on time, so thank you very much. Good night, everyone. Thank you, everyone, for coming along. And